and babies, and we do this through advocacy, through research, through provider and community education, as well as supporting families through the whole journey of pregnancy, even when things do not go as planned. And so I'm going to start off with looking at preterm birth. A lot of times we talk about infant mortality, but preterm birth and its complications is the #1 cause for infant mortality. So if we really do want to impact infant mortality, we really have to look at and impact preterm birth and drive down preterm birth. And so preterm birth and infant mortality just isn't impactful to the families who are experiencing it. It also has huge societal, economic, medical, and educational costs. So we're talking in California, the cost for societal, medical, educational costs for preterm birth is $3.6 billion, that's billion with a B, annually in California. That's about $75,000 annually for each child that's born preterm, and we're talking again the societal, education, medical costs. And those long-term effects of preterm birth, including cerebral palsy, intellectual disabilities, as well as chronic lung disease, vision, and breathing problems and hearing loss. And so this is just some data around when we look at preterm birth and race. And as we talk about birth outcomes and birth disparities, we see that Black women have the highest preterm birth rate. Their preterm birth rate is 2 times more than other races. And we also see that Latinas, their preterm birth rate is increasing as well. And then we want to also look at, when we look at LA County, and we want to just drive it down to the spas. So it's every single spa we see African-American moms have a higher rate of preterm birth than white moms. And when we look at San Gabriel Valley, which is spa 3, as you can see, it has one of the highest preterm birth rates among Black moms. And then when we look at the infant mortality rate in LA, one thing that I think is interesting as we look at the infant mortality rate, the Black infant mortality rate is this red line. And what do people see about the red line? Just put it in the chat that you see that's different from some of the lines that are on the bottom. Yeah, it's higher than others. And also too, as you can see with the other races, with Hispanics and Latinas, white and Asians, it's going down. And whereas as we see in the most recent data we have, that for Black babies is going up. So we're not seeing the decline that we're seeing in other races. Trying to figure out for some reason I'm not. Okay, and then when we look at the infant mortality rate in the spas, right? So we want to look at the different spas and see what's going on. And right again, in spa 3, San Gabriel Valley, we see that it has one of the largest infant mortality rates among Black moms in LA County. And this is what really sort of like crushes my heart, right? When we look at the Black maternal mortality rate. And so maternal mortality ratio is a death of a mom during pregnancy, childbirth, and within 6 weeks postpartum. And as you can see, Black moms have a ratio that's 4 to 6 times higher than other races. And if this isn't a call to action, if you haven't been moved before, like, this data and this number right here should just move you, because what is happening that Black moms are dying with a ratio that's 4 to 6 times higher than other races. And so a lot of times when we talk about the data, we want to look at or call out, and some others want to call out, is it education? Is it, it's low-income women who have these poor birth outcomes. It's women who don't have access to healthy nutrition. And so this really shows that looking at education, that the preterm birth rate, and this low birth weight, which is really is relates to preterm birth rate. For Black women who have post-college degrees, a master's, a PhD, they have a higher preterm birth rate than white women who've dropped out of high school. And so it's not just, it's not about education, right? And so this is when we really talk about what it is, and we really have to call out racism and call it what it is. And then when we look at birth outcomes and maternal weight, so a lot of times it's like, you know, why do people have adverse birth outcomes? It's because of they had initiated their pregnancy with underlying health conditions or in poor health. And we look at this, and we look at the weight and weight of mom for moms who had very low birth weight. So these are babies that were so likely born preterm. And so a woman, a Black woman who's underweight, normal weight, overweight, all have higher, have babies that are born very low birth weight at higher rates than white moms with the same. So if you look at moms that are morbidly obese, Black women is still higher than other women. And so I want to sort of talk about and give, excuse me, some findings on March Diamond's focus groups that we did, that we have been over the past year. And really with the findings from these groups really sort of elevates and calls out racism and the stress and the toxic stress that Black moms really experience, and really does sort of calls us to action of what are some of the recommendations. And so I'm not going to give a whole bunch of recommendations because we do have some other panelists who will be giving some recommendations, but I want to hear from you. So as I give these findings, if you have recommendations, if something calls out to you, put it in the chat. I want to hear. And so if you're like, you know, the solution to this is doulas, the solution to this is hiring more Black nurses, the solution is like policy and legislation, more research, I want to hear from you. So these focus groups that we did, we had 3 groups that we had did focus groups, listening sessions, and interviews with. And there were moms who had Black moms who had a prior preterm birth, representatives from community-based organizations that serve Black pregnant women and birthing people and their families, as well as clinicians providing perinatal care to Black pregnant and birthing people. And so we did these focus groups because we wanted to better understand the Black patient experience. And one thing that in March of Dimes that we really do, we're like in the clinical space, right? And so working with our providers, so what can we do to really increase utilization and access to some of the evidence-based preterm birth prevention interventions? And so, you know, we can't, sometimes, you know, the March of Dimes, we don't always see our role in maybe addressing some of the other social determinants of health, but what we can do when we have our strongest relationships with is with our clinical providers. And so if we have these clinical interventions that we know that work and there's evidence, how can we increase utilization among our Black moms to reduce adverse outcomes and to improve outcomes? And so we had with their moms, and so these are just some of the findings that I just want to go over and really call out. And so one of the things that I found was really interesting is that many of the moms did not know that their pregnancies were high risk until they're admitted to the hospital. And so as a result, very few of them knew about low-dose aspirin to prevent preeclampsia or 17P to prevent a recurring preterm birth. And so it really saddens me when I hear in the community, moms have had like multiple preterm births, but no one talked to them about 17P, or moms who became really ill or the babies passed away because they had severe preeclampsia, when low-dose aspirin as such is an inexpensive treatment, and really some of the outcomes, the adverse outcomes can be prevented. So what is happening that moms aren't getting this care? Moms also talked about high levels of stress, right? And so during pregnancy, they experience these high levels of stress, whether it's discrimination that they face, whether it was, you know, workplace, whether it was financial stress that they had, whether it was, with their partners or with their families. And they also felt they weren't listened to, or they were talked down to by some of their providers. And this was both in the prenatal care and in the NICU. And what really saddened me is that there were moms who were showing up in labor and delivery, showing up in the ER with signs, classic signs of preeclampsia, and were turned away. And so when you have moms who are turned away and then go home and Google their symptoms and go back and say this is preeclampsia, and the doctor's like, yes, so why weren't they listened to when they showed up the first time? Moms talked about not feeling listened to when their babies were in the NICU and not having this really supportive relationship with their provider to really have the best outcome for their babies. So what is the communication that's happening, right, between the patient and the mom and the provider? And then also too, and this would really broke my heart, that these traumatic birth experiences were so long lasting for the moms, it impacted their ability to bond with their babies, and it decreased their confidence in the early months. And when their babies were sent home from the NICU, moms talked about not feeling confident about taking care of their babies and not having enough support and information at discharge. And there are also moms who said, this experience was so traumatic, I never want to have a baby again, another baby again. So when these experiences are impacting people's feelings about being a parent and expanding their family, what can we do to really reverse that course? And then when we go back to the social determinants of health and what this is, to sort of call out the toxic stress and racism, with our participants, 82% had a bachelor's degree and 77% had private insurance. So these were well-educated women who had jobs, who were still experiencing high levels of stress, who didn't have good communication with their doctors. They weren't, didn't know about their risks, and they weren't having the relationship with their provider to really discuss the best health and plan for them as well as their baby. And this data that from our focus groups really does illustrate and pairs up with some of the data that from our local LAMB study, right, that shows that a lot of Black moms, that they are experiencing more stressful life events than white moms. And we're talking about financial, emotional, partner associated traumatic events. So all this toxic stress, right? So we're talking about, dealing with racism or economic, if it's having problems with your job, if it's feeling like you're discriminated against at your job, if it's just, listening to the TV and then some of the things that we hear, like our elected officials talking about putting down Black people, and you deal with that day after day after day, how are you supposed to grow a healthy baby and bring life into this world? And then I just want to, is there anything in the chat that sort of came up with the moms, anything that y'all feel like when you see this, this data, what do you see? So I hear that there's no training for doctors to understand the Black experience. And also to, okay. The next cohort that I want to go over is the community-based organizations. And so we had a wide range of community-based organizations that have participated in the focus groups. So there's, everyone from when we think of those that are on the ground doing work, as well as counties, government agencies, and those providing perinatal care as well. So some of the findings, and they agree that, the cause for these racial disparities is a combination of racism, historical factors, stressors, as well as an unsupportive healthcare system. And and this was really interesting too, that the Black women felt, or the women who were Black who participated, felt that they were rarely in leadership positions or decision-making roles in their organization. And so even though in their organization, they would pair up Black staff with Black patients, or that the Black staff had more interaction with the Black patients or clients or participants, they had less leadership and less decision-making power in their organization. And they also talked about a lack of coordination and cooperation between community-based organizations and those in the medical field and healthcare providers. And this was really interesting, and it's one of the reasons why with our focus groups we did look at these 3 different groups, is because we know that, you know, women go to their health provider and they tell one thing, they go to BIH or Black Infant Health and they're telling their BIH coordinator one other thing, they're going to Black Women for Wellness and they're telling Black Women for Wellness something else. So their doctors aren't always getting everything that's going on because of the trust. The CBLs also felt that they wanted the professionals to be more accountable for the disrespectful and unresponsive care. And they also felt that culturally matched care, so matching Black participants with Black staff, yields better results. And so they really implored Black or organizations to hire more Black staff. Oops. And so is there anything for those on the line, when you hear, if you work for a community-based organization, or if you're a participant with Black Infant Health or any of the other local organizations, is there anything that that resonates with you? So I say that all doctors can relate to us, and there's no way they get to treat Black patients what is required and reserved. Okay. And then with the clinicians, we have some of the feedback that we got was that they felt in this fast-paced, volume-based healthcare system, they don't have opportunity to develop these relationships that are built on trust and understanding, the way this person put in the chat. They also really iterated that the healthcare system is unwelcoming and not supportive. And they recognize that Black mothers experience high levels of stress. And so what can happen within the healthcare setting that can help relieve some of that stress? What can, who can doctors refer their patients to increase their social support? And then also to, the clinicians that they were frustrated when moms didn't accept or adhere to preterm birth interventions. So what was happening in that communication, right? Because back when we heard what the mom said, that they didn't know that they were at risk, they weren't aware of some of these interventions. So there is this breakdown in communication. And then also to, a lot of the clinicians said that they want to do more, but they lack, whether it's the institutional support or education opportunities or funding to really drive change in their institution. And so how can we elevate leaders, in our healthcare system? How can we not just hold them accountable, but also to make sure that they are, that all doctors have the training and the funding and the support that really have to drive some system changes in their healthcare settings to really improve the health of Black moms and babies. And so I know I'm at time, and one thing that I hope with this sort of drives home is that, when we talk about the health experiences of these moms was, not that they didn't have enough food, not that they were overweight, but really it's a toxic stress that they experience. And so this is really, for me, personal, because this is a picture for me from my Black graduation when I graduated from UC Berkeley, and it's my 3 sisters. And so I have a sister who went to Stanford, I have a sister who went to Duke, I have a sister who's a physician. I have a sister who's getting her PhD in science education. We're all college educated, and we've all had babies 37 weeks or less. So we've had babies at 24 weeks, we have had babies at 27 weeks, and we had babies at 30 weeks. So this is not about, and some of us were vegan when we were pregnant, so this is not about our education, not about our access to care, not about our health status, but really about the toxic stress and experiences living as Black women that impact our health outcomes. And so I just want to thank you all for having me today, and I'm leaving you with some references and research and resources to dig more into this in terms of when you look at toxic stress and birth outcomes. And also just want to thank you and leave you with my information. So I am always here to help and work with you in any way, in any capacity that I can, to make sure that we are improving the health of our Black moms and babies, and that we really are increasing the social support and making sure that we all have the opportunity to have these healthy and joyous births that we deserve. So thank you.
Thank you so much, Mashariki, for giving us that really great, powerful introductory data presentation, but also linking it to the findings in your work and to your own story. So thank you for that. We do actually have some really great comments in the chat. There are people who are sending comments in the chat, but just to the panelists. So just be aware when you're typing into the chat that you can select to all panelists and attendees so we can all see your questions and your comments. And there will be some time for Q&A at the end, so you'll have a chance to ask questions for any of your, from any of these guests today. Next, we're going to hear from a physician, Dr. Tasca Moore. For almost 15 years, Tasca Moore has cared for women in underserved communities in the field of obstetrics and gynecology. Her commitment to impoverished populations has led to mission trips around the world, including countries in the Caribbean, Asia, South America, and Africa. Dr. Moore believes that change begins with healthcare providers. As such, she has advocated for diversity in the workplace and launched staff-centered health campaigns. Dr. Moore's career in medicine is expansive, with experiences in the area of academia, community medicine, research, and utilization management. The culmination of her career has led the founding of an education and coaching digital platform for pregnant women called Healthy Bump Club. The organization, launching soon, provides a multi-specialty approach to addressing the most critical maternal health issues, especially for women of color. Dr. Moore lives by the motto that if you help one woman, you can change her entire family, which can then change our community. The presentation, Dr. Tasca Moore will summarize the Black experience in healthcare and navigate us from a historical perspective to current trends. Please join me in welcoming Dr. Tasca Moore.
First, I wanted to say thank you guys for having me. This is a pleasure and an honor to be on this panel to discuss this very critical topic. So, Black women's health does matter. We know this. But what I would like to do is to take us to a journey, to look historically to see where we are now so we can come to a place of healing. As we know, this topic is becoming more and more, gaining more and more attention, and you may have become more aware of the matter in regards to some of the recent social events. Some of us have been following these numbers for a number of years, and it's really disappointing that the U.S. is the only developed country that is seeing an increase in maternal mortality. Some of the more recent relevant events include Kyra Johnson, who happens to be the daughter-in-law of TV judge Glenda Hatchett, who died in 2016. She is the reason why her husband came before Congress to present the importance of this topic. Some of us may be aware of Serena Williams' experience with her diagnosis of a postpartum pulmonary embolism. She reports having the experience of having delayed treatment. Most recently, there's been notice of Erika Samantha Trim, who actually was a member of Obama's administration. She recently died on June 23rd as a result of a week after having an emergency C-section in which she delivered 30 weeks gestation. And most recently, as mentioned, is Shaeja, who died in my hometown, Brooklyn, New York, at Woodhull Hospital following an emergency cesarean section. And also Amber Rose's death has also become public news. So if we are going to have a conversation about maternal mortality specific to Black women, we have to discuss it in the context of racism. Racism is the foundation of the founding of this country. And as a result of that, we can see elements of racism throughout healthcare, from the start to where we are currently. You can look at racist events, which includes the defunding of the Freedmen's Bureau Hospital, the fact that Black soldiers were exposed to toxic chemicals. The Tuskegee experiment is one of the most infamous examples of racism in healthcare. The fact that Henrietta Lacks took many years before she received the acclamation she deserved for her contribution to medical science. We can also talk about the fact that Flint, Michigan still does not have clean water, or we can look at the disparities that are being magnified as a result of COVID-19. There are some foundational ideologies that really lay the groundwork as to the racist examples that we are seeing today. Dr. Samuel Cartwright, ironically, who is known for his work in mental health, wrote that Blacks bore a Negro disease, making them insensible to pain when subjected to punishment. There are other ideologies that are based on the theory that Blacks have thicker skulls but smaller brains, that we're less sensitive to nervous systems, that we have innate diseases related to our darker skin, that we age slowly, and that our couples are more fertile, which we know isn't true. Let's talk about the Black don't crack theory. So I bring this particular one up because this is one that has been a point of pride amongst the Black community. The fact that the amazing benefit of melanin and that it helps to delay the physical aging on the outward appearance. However, there are new studies that are now showing that on the cellular level, that in fact we actually age more rapidly. This is important because this particular assumption leads to the possibility of missed or delayed diagnosis, just based on the sense that perhaps we're not in the age group that may suffer from the comorbidities. But in reality, we're actually experiencing some of these comorbidities at much younger ages. And then we have the disparities in pain management, which was previously mentioned. I wanted to highlight specifically that in 2016, there was a study done by the AMFC, which is the Association of American Medical College, which identifies that trainees who believed that Black people are not as sensitive to pain as white people were less likely to appropriately treat Black pain. We also know that studies have shown that Blacks are less likely to receive timely pain management in the emergency room. And when we have more severe pain, it's oftentimes unmedicated. Often this is related to the assumption that there's a higher risk of abuse of narcotic medication in the Black community, which has not been found to be true. James Marion Sims, who is known as the father of gynecology, is known for his development of the Sims speculum, which we do use for pelvic evaluation. He's also known for his pioneer surgical techniques in the repair of fistulas. What has not been as much broadcasted is the fact that his research was done on enslaved Black women without the use of anesthesia. And interestingly, once he perfected the surgical procedures, he then performed these surgical procedures on white women with the use of anesthesia. Yet he's memorialized with statues in three of the states. I wanted to highlight the names of women that we do know endured some of his surgical procedures: Lucy, Anarcha, and Betsy. Anarcha specifically was a teenager who endured 30 of these procedures. There are evidence of disparities throughout women's health. Black women are 60% more likely to have hypertension than white women. We're 3 to 4 times more likely to have fibroids, which is still the #1 cause for hysterectomies. We're more likely to have open abdominal hysterectomies, as per a recent study that was published last year, meaning we're less likely to have least invasive approaches, which has not just physical consequences, but also economical consequences due to the longer recovery period. We're more likely to have preterm deliveries, as mentioned, and we're also more likely to lose our babies before the first birthday. We're 3 to 4 times more likely to die from pregnancy-related complications. So let's take a deeper look at that. The why is the biggest question, which everyone has been addressing today. We've looked at education, insurance, income, immigration status, family history, geographic location, but one of the most consistent findings has been this theory of chronic stress. This is important because chronic stress results in inflammation, and chronic inflammation contributes to some of the comorbidities we've mentioned today. So let's talk about what it's like living in America as a Black woman. So racism has rooted through almost every aspect of life in America. It impacts our access to food, employment, quality healthcare, safety, education, and the list goes on. And these are just some of the examples. What this shows is that every single day that a Black woman steps out of her home, she encounters multiple episodes and incidents that are laced in racism. And then when she returns home and she turns on her TV for entertainment, she then encounters multiple examples of racist-based commercials and TV programming, which leads to the chronic stress that we've been talking about. Chronic stress has a effect on almost every system in the body. It leads to multi-organ damage. Specifically looking at the immune system, emotional and psychological stress activates the immune system and releases pro-inflammatory cytokines. This is important because maternal fetal immunity is a very complex system that has a role through every trimester of pregnancy, starting from implantation all the way through the onset of labor. When we look at the stress hormone cortisol and we look at its impact on the body, we see that the impact it has on the body also correlates to some of the disproportionate diseases that are causing either higher mortality rates or just higher incidence in the Black community. Specifically looking at the fact that it results in a decrease in serotonin levels. We know that Black women are less likely to receive maternal mental health services. And then we see that it has a role in the deregulation of our sugar levels, which can be correlated with obesity, as well as gestational diabetes, and its impact on the blood pressure certainly makes preeclampsia a more consistent finding. So when we look at short-term stress responses and long-term stress responses, there are certainly some areas and consequences that I wanted to highlight. We talked about the elevated blood pressure, deregulation of sugars, and we also talk about the impact of cardiovascular disease. Well, interestingly enough, when we start to look at the top causes of maternal mortality, we find that now we're having an increased number of women who are pregnant who have chronic diseases, specifically hypertension, diabetes, and chronic heart disease. When we look at the combined cardiovascular conditions, we find that these particular conditions account for more than 1/3 of pregnancy-related deaths, according to the CDC. We are now enduring the effect of COVID. Well, let's look at the risk factors for complications related to COVID. We find that the same complications overlap with the same chronic diseases that are impacted as a result of chronic stress issues. So we've talked about representation matters, and this is important because Black women are beginning to voice that they receive better quality care when they are cared for physicians who are also Black. So what does this look like for us? Currently, we know that about 5% of physicians are African American. So what does this look like in the numbers of the population? You'll see on the right side of the slide that given our current population, 13% are Black, which leads us to a number of 43.8 million. 1.1 million physicians, and this does include inactive physicians, but we'll take it for face value. If we were to compare the numbers, you're basically trying to match 55,000 Blacks to take care of a population potentially of 43.8 million. We have a long way to go. When we look at some information that's been released by the Association of American Medical College also, we're seeing disparities in the matriculation through medical college. in which Blacks are less likely to matriculate and graduate through. There is less representation in faculty. Faculty is still predominantly white and male. And there's also trends now in terms of gender. We're seeing a decrease in enrollment of Black males going into medicine. Then we talk about, so where are Blacks likely to go? Are we employed in the community? So in order to really make Blacks available so that we are available to our own community, we have to look at some of the other complicating factors, and this is just one example. Black doctors are more likely to have a higher debt-to-income ratio. Higher debt-to-income ratio, it's going to be hard to retain doctors in community centers unless we make funding more available to levy off some of the disparities. Then we will look at leadership in medicine. We find that though this particular slide is looking at minorities as a whole, we know that minorities consist of 1/3 of the hospital population, but when we look at the leadership within a hospital arena, we find a huge deficit and a lack of representation on all levels, from board members to executive leadership, CEOs, and managers. So we've come to a place that we all know that it's time to heal. The question is the how. How do we heal as a community? How do we heal as a society? Well, let's start with the fact that we need to redefine a few things. Racism is not a public health issue, it's a public health crisis. Why is crisis important? It's important because it adds a certain level of urgency. When we deal with crisis situation, as we do, for example, with COVID-19, it releases certain resources, allows us to maneuver through this particular topic much quicker. And if we are able to, in order for us to be able to address this particular issue, we have to treat racism like we do any other public health crisis. It has to be studied, and we have to go to the depths of it and uproot the toxic roots that have led to the system that we function in currently. So what does this mean? The first thing we have to ask is, do we even know how Black women heal? Healing for this particular issue is going to require systemic approaches and individual approaches. We have to keep in mind that what we're asking Black women to do, especially in a society where there's repeated trauma, is we're asking Black women to heal while we're hurting. We also have to acknowledge the fact that we are a selectively dismissive culture. I'll give you an example. The context of slavery is always such one that is said, let's forget slavery. It's time to get over slavery, which is interesting because slavery resulted in the death of millions of people. But when we look at the context of other events, tragic events that have happened in the US that affect more of a multi-ethnic group, then the hashtag becomes never forget. Then when we talk about post-traumatic slave syndrome that has been described by Dr. Joy DeGruy, we have to acknowledge a few things, that we're dealing with long-term trauma. And as a result of that, there is adaptive behavior that's both psychological and physiological. We also have to deal with the fact that the outlook of Blacks on life is very different, especially when you're dealing with a shortened life expectancy. So what do? We have to trace the imprint of racism throughout our entire healthcare system, not just looking at matriculation through medical school, but let's go before that. Let's look at those who desire to become doctors. Are they getting even to medical school? And after medical school, how are we matching into residency programs? Looking at those numbers. Are we putting funding into women's health to begin with? And especially so, are we putting funding into issues that specifically affect Black women? Who are on the committees that are deciding the journals that are being published? Do we have representation there? Do we have leadership, not just in the hospitals, but how about in the insurance companies and the pharmaceutical companies? What do our leadership look like? And then are we supporting Black doctors who want to go into the community and be able to sustain their practice? We have to also highlight things that are showing us that there are changes. The reason why this is important is because whenever there's a major change, it's a sign of hope. And that sign of hope makes a difference from the outlook of Black women. We also have to build trust. And I say build trust because we've never had trust. So there's no rebuilding. We have to initiate by starting to figure out, how do we build trust between Black people and the healthcare system? I'll give an example as to why this is important. So Melinda Gates got a lot of backlash recently due to an interview with Time magazine. And it's over a statement that appears on face value to be very benevolent. Why shouldn't Black people, considering our disparity with COVID, not be the second group behind frontline healthcare workers to be vaccinated. Well, on face value, this looks like a very benign statement. However, when we put into the context of the relationship between Black people and the healthcare system, in which we have been experimented on multiple times, this raises question and it becomes an alert. And that was the foundation of the root of the backlash. Then we need advocates. I'm happy to say that ACOG is making some efforts to be an advocate in this particular arena, committing to changing the culture of medicine and eliminating racial disparities. We're still struggling with how exactly we actually get that done, but this is a good first step, the recognition that there is a problem. Then we can have a conversation, which we already did have a meeting to start this dialogue, to try to figure out what role we play as a professional organization to making some of these changes. How do we get Black women to have healthier lives? Well, as mentioned, first we have to recognize the fact that Black women are less likely to be cared for by someone who is culturally competent. So why is this important? That means when she steps into an office, she is likely coming with multiple episodes and experiences of just bad experiences with healthcare. So she's coming already with a level of distress. And I would encourage all clinicians to start off by getting an understanding of what her experience is. It's more than just writing medications, it's understanding the context in which she's coming into our office. And then when we talk about representation, it's made clear that Black women are definitely, compared to Black men, in higher numbers in women's health. And so in saying that, we have to understand that Black physicians and clinicians are also patients. So what that means is that we have our own experiences in which we too have experienced some of the disparities of healthcare. And that has to be placed into context, because that means the same physicians that we're relying on to be the front runners in this conversations also are the same patients who also have had the same bad experiences. And of note, this conversation that I've noticed has started on a national level. I've watched some of the interviews and they're not with Black physicians. So what must we do on an individual level? Well, first, we have to acknowledge the fact that regardless of our moral principles of our family, education, and faith, we are all nurtured to some degree by racism. Racism is present even in the absence of a racist. It is much more subtle. I saw someone write that in the chat. It's much more subtle than it is blatant, and it's not always violent. And then we must do our own self-evaluation, meaning ask ourselves the question, am I a racist? Seems like an odd question to ask, especially with minorities not, by the context of racism, not able to be racist. But this question is important because if we start to normalize asking this particular question, it removes some of the offense that happens as a result of asking the question. What happens is most people get offended by being even considered to be a racist because their association is with the most violent experiences. But what we really have to do is to get to the point where we're able to do that self-evaluation. Then asking, how has racism affected my health? What experiences have I had that demonstrate the impact of racism in my life? And then asking, have I embodied any of those racist ideology? For example, Black don't crack. That's something that we have embodied as a community, but we must look deeper into these issues. And then finally, we must commit to remain actively conscious, always asking with every policy, with every program, with every protocol, with every workflow, whether or not there are undertones that are racist. And it's only then that we can lead to a society where Black women can begin to heal.
We also have the pleasure of hearing Dr. Kim Gregory, who is the Vice Chair, OBGYN at Cedars-Sinai Medical Center. Please join me in welcoming Dr. Kim Gregory.
So I'm going to be talking about advancing equity in maternal mortality, steps for clinicians to reduce barriers and improve quality of care. These are my disclosures. And I want to emphasize that I'm sharing my own opinion. It's based on my perspective of being a maternal fetal medicine subspecialist and educator within an academic tertiary care community hospital. My experience on the California Maternal Quality Care Collaborative Maternal Mortality Review Committee. My quality improvement experience. My experience with the healthcare system as a client in the caretaker role. My experience being an African-American female, mother, sister, and friend. And of course, I have no off-label use of medications. So we'll talk about healthcare disparities in medicine and as it relates to maternal mortality. And I want to invite us to reconsider evidence-based protocols to minimize adverse outcomes and maternal morbidities associated with maternal mortality. So we're all very familiar with healthcare disparities in medicine. There have been multiple treatises published on it, and they've all found pretty consistently that compared with whites, Black patients are referred to see specialists less often, they receive less appropriate preventive care, have fewer kidney and bone marrow transplants, receive fewer antiretroviral drugs for HIV, and get fewer prescriptions of antidepressants for diagnosed depression. They are also admitted less often than whites for similar complaints of chest pain. And these disparities are not just limited to Black people, it's other people of color. Blacks and American Indian and American natives receive worse care than whites for about 40% of all healthcare quality measures. Asians receive worse care than whites for about 20% of measures. Hispanic receive worse care than non-Hispanic whites for about 60% of core measures. And finally, even green matters in that poor people receive worse care than high-income people for about 80% of core measures. So the consequences of this are monumental in that there are more deaths, needless hospitalizations, and wasted resources to the tune of about $1.24 trillion. And then when you add gender, the race-gender intersection, it's the double whammy. Women share many of the problems experienced by minority groups in general and by women as a whole. However, race discrimination and sex discrimination often intersect so as to magnify the difficulties minority women face in gaining equal access to quality health care. And this resonates with us by the Serena Williams birth experience and the Black Mama Matters initiative that, thank goodness, has taken the country by storm. So what do we know about maternal mortality? This is different countries that we like to compare ourselves. And you can see that for almost all countries, the maternal mortality rate since 1908 has been going down. Of course, in America, where it's been going in the wrong direction. And this is what's happening nationally recently. The blue is the country. I'm wrong. The red is the country, which is probably poignant in that it's going up. But in California, it's going down. And California is a blue state. And it is going down, and it's been going down since about 2008. And we think that that is because of the maternal mortality review committees. The lessons learned were turned into quality improvement initiatives. Many of you will have heard of them through the California Maternal Care Collaborative, or the CMQCC, and the AIM bundles. And we believe that that made an impact in the maternal mortality in California. Now, as we were seeing here, that for California, it was about 2013, it was 7.3. It's actually a little bit higher now. And for the state, it was 22. But if you look at it by race, Black Americans or women had about a 3 to 4-fold higher rate. And as Mashariki pointed out, there's some data to suggest that it's even higher. So when you put this in the societal context, the Healthy People 2000 goal was to reduce health disparities among Americans. And in 2010, they expanded that to say, let's eliminate, not just reduce health disparities. And then Americans being Americans got fancy and made the goal even further to achieve health equity, eliminate disparities, and improve the health of all groups. Now, needless to say, we've done none of this, but that hasn't stopped us from upping the game for 2030. And now the societal goal is they want a society in which all people can achieve their full potential for health and well-being across the lifespan. And they want to do this by achieving health and well-being. Achieving health and well-being requires eliminating health disparities, achieving health equity, and now they've added attaining health literacy. And I think that becomes an important goal when you think back on some of the things that were learned in the focus group about people not even knowing that they were high risk. So disparities is often interpreted to mean racial or ethnic differences. And this is especially true in health. And if a health outcome is seen to a greater or lesser extent between populations, then there is a disparity. On the other hand, when we talk about equity, it is the attainment of the highest level of health for all people. Achieving health equity requires valuing everyone equally with focused and ongoing societal efforts to address avoidable inequalities, historical and contemporary injustices, and the elimination of health and healthcare disparities. Now, we've all seen these cartoons where this is equality, where everybody gets the same thing, but they're not having the same results if the goal is to see the field. This is equity, where you give people the resources they need in order to achieve the same goal. However, we know in reality, it's not equality or equity. The reality is that some people are getting extra and many people are not getting enough. And so this is a significant disparity here. And I think what we want to strive towards is liberation. We can't just tell a different version of this same story. If we really want to see change, we need to change the story. And so how do we take the fence away? So that's sort of where this whole concept of implicit bias has come about. And that even though it is perhaps potentially different and less malicious than intentional racism, it has equally harmful results. And because implicit bias is subtle and hidden, it allows discrimination in healthcare to persist. So until we openly give voice to the problems of implicit bias, although I like to call it explicit bias, inequity of care, and the impact of segregation on access to care, we won't start to achieve meaningful change in healthcare disparities. So I want everyone to take the opportunity to take this test, implicit.harvard.edu, so that you can see your own implicit biases, and trust me, you have them. But basically, I want to reinforce the fact that it's not necessarily your fault, but it is your fault if you don't do anything about it. Our culture perpetuates these biases. A database that contains the books, magazines, and articles that the average college-educated American would read over his or her lifetime. And the study was a really simple one, and it said which words are commonly paired by race. And what they found is that when the word Black appeared in American culture, it co-occurred with poor, violent, religious, lazy, cheerful, and dangerous. However, when white was written, the frequent words that co-occurred were wealthy, progressive, conventional, stubborn, successful, and educated. If you have not seen the Jane Elliott's Blue Eyes, Brown Eyes experiment, I really implore you to do so, because this shows you how easy it is to become prejudiced. And it takes about 13 minutes, so I'm not going to share it with you today. But what I want you to know is that what's learned from this experiment is that racism and implicit biases are taught by socialization and peer pressure. And what's neat about that is that if it is taught, it can be untaught. And that is why people are arguing for implicit bias training. Although the evidence, we need to build the empirical evidence to show that these experiences and trainings will make a difference. So using the California Maternal Mortality Reviews as a springboard, what do we know about maternal mortality? And given what we know, what can we do about it? And if you will recall, the rates of maternal mortality were going up until about 2008. And in California, the rate started going down. But what I want to emphasize here is that if you stratify it by race, it stayed the same for most major racial groups except for African Americans, which is here shown in red. And so it is theorized that the reason why the California maternal mortality rate dropped so significantly in California is because of the decline in maternal mortality for Black women, and that this decline came because we introduced these toolkits that help standardize care. The other thing that's really important to note is that maternal mortality is significantly affected by age, so that for every 5 years up you go in age, the maternal mortality rate increases. And that this is exacerbated by race, so that if you're older and African-American, your maternal mortality also increases. People always say, oh, well, part of the reason why the maternal mortality rate is going up is because people are sicker and there's more disease, and that is true. Hypertension, diabetes, and asthma have all gone up over time, and it varies by race, ethnicity. So for example, hypertension increased most for American Indian and African American women, whereas diabetes increased more for Asians and Hispanic women. And the other thing, as Mashariki pointed out earlier, is obesity is a huge contributor. Of all of the deaths in California, almost 60% of them, the women were overweight or obese. And I just sort of want to point out that this does allow us an opportunity to think about what is preventable. We're not blaming the victim here. What we are trying to say is, what are these things that you can do something about? And theoretically, you could have your kids earlier so that you were younger and healthier. You could have your kids when you're at a more ideal weight. You know, you could have your kid when your diabetes and hypertension are optimized. So when we look at cause-specific mortality, again, I want to emphasize that it is going down. These are 5 years time periods. And so the rate of death by hemorrhage has gone down significantly. And we think that this is due to the standardized toolkits for the management of postpartum hemorrhage. Similarly, the rate of death due to hypertension disorder has gone down. We think this is because we're now treating hypertension more aggressively. There hasn't been that much change in death by infection, but there has been a decline in death by thromboembolism, or blood clots to your lungs. And again, that's because we now argue or do have some standard treatment prevention protocols. But if you remember that this is always relative to 100, as we get better at some things, the morbidity from other things starts to go up. And one of the things that's really standing out significantly is that the rise in cardiovascular and cerebrovascular or stroke is going up. And some of that is due to hypertension and obesity, as well as diabetes. So it is something that we're definitely looking out for and developing a toolkit for. And these other conditions I just want to mention briefly is suicide and homicide. And so as we get really good at some things, it causes us to look at other places where there's opportunity. So one question comes up, is the difference due to prevalence of disease or case fatality? And unfortunately, it's case fatality. So if you look at preeclampsia, Blacks have a little bit more preeclampsia than whites, about 20% more, but this difference is not statistically significant. However, among people who have preeclampsia, Black women are 2.7 times more likely than white women to actually die of the disease. Similarly, if you look at postpartum hemorrhage, Blacks actually have fewer instances of postpartum hemorrhage, but they're more than 3.3 times more likely to die. So these, and again, these are preventable deaths. And so we'd like to learn from how we can benefit from that. And one of the questions comes up, well, is this due to implicit bias? Are we ignoring these women? And it's probably not ignoring. Some of it is that people are busy, and when they're busy, they rely on their stereotypes and multitasking, and or aren't appropriately going up the chain of command. So again, we think that the bundles are helping to mitigate against some of that. And that by doing the bundles, you're getting rid of the systematic inherent biases. So approximately 60% of maternal deaths are presumed to be preventable or attributable to provider or health system limitations. And these can be reduced to delays or inadequate diagnosis or treatment, use of ineffective treatment, misdiagnosis of condition, or lack of resources, delayed transfer, and access to prior records or visits. So I'm going to go over some examples about that. So what we learned from our maternal mortality reviews in California was that the timely diagnosis and standardized evidence-based medicine for specific conditions could improve the outcomes, specifically as it relates to the management of hemorrhage and preeclampsia. We also came up with early warning signs, so that if the patient had pain or heart rate greater than 120 or a drop in her oxygen saturation, then it meant automatically that the patient had to be seen by a physician on deck, and that it wasn't subject to the nurse deciding if she should call the doctor. If you met this criteria, you not only had to call the doctor, but the doctor had to come see the patient. Clinical coordination of care of patients with multiple comorbidities. If you have somebody with diabetes and hypertension, they should be managed with the OB and either MFM or OB and an endocrinologist or cardiologist, someone who's familiar with these conditions. One of the things that's really unfortunate is you have a lot of hospitals that take Medi-Cal for OB care, but then those same hospitals' private physicians don't take care of those medical conditions that those women have. And so that's a disconnect, and it leads to sometimes an obstetrician managing clinical conditions that are above and beyond what they usually do in their day-to-day training. You want to optimize the maternal health before, during pregnancy, and postpartum. This is the whole preconception, interconception, and now the fourth trimester of postpartum period. And hopefully with this new passage of the law where you have care beyond for a year postpartum, we would like to see from a population-based basis an improvement in outcomes. Mashariki mentioned that many women did not even realize that they were at risk. And I think the one take-home point I want to leave today with everybody is if you're African American, you're at increased risk. There's almost no such thing as low risk. We want to be able to support and replicate local projects that work and improve the hospital's ability to respond to OB emergencies. And so I want to sort of wind down and conclude with, or leave everyone with the thought that we need to acknowledge that women of color are different, and therefore they should be treated differently, both individually and as a group. So how we measure that difference is probably yet to be determined. We definitely don't think it's genetic anymore, but it could be metabolic or proteomic or social. Everyone's talking about the allostatic load that we experience. But we know that globally, across the world, maternal risk for women of African ancestry is greater. And that's not only in Africa, but in every country where we have migrated. And that the disparity is not adequately defined by socioeconomic differences. So we need to learn from places where maternal mortality is improving, approach the national maternal mortality gap by treating or conceptualizing care for Black women as though they were receiving care in a developing country. Developing countries are lowering their maternal mortality rate, and things that we've learned from them is that it needs an ongoing political will to address the problem. So again, hashtag thank you, Black Mamas Matter, and Black Lives Matter for that matter. But as long as it is a political will, we can see a difference because money and public policies will be directed towards change. We need skilled and interested birth attendants. Thank God for that doulas are now becoming the mainstay or more prominent on the floor. But importantly, we need to change providers' attitude and improve communication. We need providers that look like us. We need the continuity of providers and accountability between inpatient and outpatient. And this is especially true if it's not within the same system of care. And I think we definitely need to see more mid-level clinicians. So they're telling me that my time is up, but I do want to leave with a few thoughts, and that is the importance of contraception so that our pregnancies are timed for our lifestyle, and that we want to address education and economic empowerment early, especially for teens and young adults. And then I think I'll leave there and come back for later for questions and answers, period. But there are things that can be done, and there are things that we are doing.
Our next presenter is a mother who recently gave birth and is willing to share her personal birth story and the challenges she faced. She will also provide some concrete advice. Stella Klingman-Simon is the mother of a 23-month-old and a former participant in the Black Infant Health Program. A maternal health advocate, Stella currently serves as the Maternal and Child Adolescent Health and SIDS Coordinator for the Pasadena Public Health Department. She has imbued her birth and postpartum experience into her work, advocating for funding to support women's access to perinatal support personnel, such as doulas, and improving birth and breastfeeding outcomes for Black women. Stella holds a Master's of Public Health degree from the University of North Carolina at Chapel Hill and a Bachelor of Science degree in Foreign Service from Georgetown University. Please join me in welcoming Ms. Stella Klingman-Simon.
Hi, thank you so much. I'm so grateful for this opportunity to just share my experience. As a mom, my son is almost 2, so I guess it's not too recent, but it feels very recent. So what I wanted to just share, that my son was born early on a Friday morning, and I realized probably about a year later that that was not an accident. I found out I was pregnant about 4 months after my husband and I got married. I was living out of the country at the time. And so my pregnancy was unplanned. I actually had a failure of birth control. I had an IUD at the time. And even though I had a background and expertise in maternal and child health, I was really scared. You know, I had no time to prepare. I wanted to spend that year getting healthier, working, preparing myself for pregnancy that I eventually did want. But I ended up moving back to the US, and I was able to get emergency Medicaid while I was looking for a job. And I found an OBGYN near me who accepted Medicaid. But one thing I do want to say is that it was pretty difficult sometimes finding an OBGYN. There just aren't enough that accept Medi-Cal, and few that do often have huge caseloads because the reimbursement is low and the demand is high. So oftentimes I felt kind of like a factory, you know, going in there. Sometimes I would spend 2 hours before I would be seen, and my visit would maybe be 10, 15 minutes max. And I remember feeling like I had to write down all my questions ahead of time, because if I didn't ask it within those 30 seconds after my appointment was over, it was almost like he was out the door and I had to kind of, you know, track him down. So it was kind of like I had to prepare everything ahead of time, make sure that I knew what I was going to say, because if I hesitated, he took that time and I didn't get it back. And so during my pregnancy, I had quite a few stressors in addition to just the normal stressors that we as Black women face. My father was diagnosed with prostate cancer in February. And then later, about 2 months before I was due in June, my aunt, who was very close to me, she is a maternal and child health expert, she passed away unexpectedly. And the day that my son was born, my grandmother, my only grandparent, ended up going into the hospital, and she died 2 weeks later. So I was dealing with quite a lot of stressful events on top of sort of, you know, navigating, looking for a job, you know, and not really knowing exactly how I felt about my OBGYN. So I kept telling myself, okay, if I can find a doula, if I can find an advocate, somebody to kind of be there with me to help me, then I can stay with him. I looked for a doula. I couldn't afford one out of pocket. This was before some of our amazing LA County doula programs came into effect. And I remember linking up with someone about a week before my due date. And she ended up giving me a call back and found somebody, but I didn't get that message because I was induced the day before that. During my pregnancy, throughout my pregnancy, I didn't feel very valued. I didn't feel heard or seen. When I remember specifically when I told my doctor that I wanted to have a natural birth, he didn't support me, basically saying that, you know, I most likely would want and need an epidural. 90% of women did. And when I told him I wanted to write a birth plan, he essentially told me that it wasn't necessary. So I almost didn't bother because I kind of knew he wouldn't read it. And throughout my pregnancy, I remember one thing that kind of seemed constant. It was that throughout, he stressed to me that the longer I stayed pregnant, the likelier it could be that I might have a C-section. So there was this constant sort of telling me and worrying me that, you know, make sure you take walks, and you just don't want to stay pregnant too long because that increases your likelihood for cesarean section. So fast forward to my last month, when you have your visits every week. And I remember they told me that, well, the weekly visits are only on Thursdays. And so I remember thinking, well, that's kind of strange, you know, not really understanding why that was, didn't explain it. But I soon found out why that was. Sure enough, the Thursday after my due date, which was the previous day, Wednesday, my doctor told me that I had low amniotic fluid and to meet him at the hospital. And so confused, I kind of said, so does this mean I'm giving birth today? And he was like, yeah, yes, meet me there. So, you know, I did what he said. I got all my bags. My husband and my family met me there. And I was given Pitocin. I was induced. And I remember probably about 4 hours in, the contractions really started to hit. And they were constant. They were strong. They were very hard. And I remember the nurses coming in looking really, really worried because they could see it on the monitors and were just, you know, and kept, you know, and asked me, you know, are you okay? Is this, you know, and I remember wanting to delay the epidural at least. I didn't really want one. I wanted to be able to walk around the hospital. I couldn't do any of that. I couldn't stretch. I couldn't sit on a birth ball, nothing, because I was, I had an IV. So I was basically confined to the bed. And I wanted to delay the epidural because I didn't want to, for it to slow down my labor. But probably around 11 p.m. that night, it was just too much to take. And so I got the epidural. And I was able to sleep for about 4 hours until about 3 a.m. when my doctor came in and told me I was fully dilated and to get ready to push. And so at this point, the epidural is still in me. I have to ask a nurse to get somebody to take it out so that, you know, maybe the effect can come off and I can try and start to push. But that wasn't enough time. And I don't know exactly how long I was pushing, but it was around 3 when he came to check me, and my son was born about 5:30 that morning. It was very difficult pushing him out. And in fact, I almost just felt like I wanted to give up, you know, and actually the person there that really was so strong and really helped me was a Black visiting nurse from Victorville. Most of the nurses at my hospital were not Black. In fact, I didn't see any nurse that was Black except for the nurse who came when it was ready to push. And she was basically my doula. She, when I wanted to give up, she wouldn't let me. She gave me ideas. She let me understand what I needed to do. And eventually I got my son out. However, because of all that pushing, he ended up having 2 large hematomas on his head, which I think contributed to the jaundice that he later developed because he wasn't eating and he wasn't able to expel that. And so he ended up developing jaundice. So he was born that Friday morning. And by the next Saturday, the day after, I had a perfectly healthy pregnancy, but I remember asking them to turn down the air conditioning because it was freezing, and they told us that they couldn't. They had to get a facility person. Anyway, after maybe 5-10 times asking, it never happened. And I noticed him, my son, breathing really quickly. And so I asked the nurses to check him, and they went and they came back, and basically they brought the neonatologist, and he said to me, if it were my grandchild, I would want him to get antibiotics and to put him in the NICU. Basically, they didn't know what kind of infection he had, but he had some sort of infection. And he was pretty much immediately given a bottle. I know he needed to feed, but there was no talk about, even feeding him with a spoon, feeding him with another type of feeding device. And, you know, and I didn't know. When I was told before I gave birth that there would be a lactation consultant at the hospital. So when I got there, I expected to be one. And they told me there was no lactation consultant. So I didn't receive very much lactation help. The nurses basically told me to breastfeed, but that hands-on, that education, it just wasn't there. And so for me, you know, it was very hard, and my milk didn't come in, and it was very hard to feed him. And so when he was given that bottle, basically he drank it up. And I remember visiting him, you know, throughout that week that he was in the NICU for about 8 days, and pumping and bringing in breast milk and trying to, you know, get him to latch, but he was never able to latch again. And this is a baby-friendly hospital. So just that conversation that never happened of maybe we could talk about an alternative feeding, but really he was 2 days old and he was immediately given a bottle. So for me, some things that I took out of this was that even for me, somebody who has expertise in maternal and child health, who had a completely healthy pregnancy, I had no problems, and my son still ended up in the NICU, and I was not able to breastfeed him. So there are a lot of different things that can come into a birth experience, and for me, a lot of the preparation, a lot of the knowledge, once I got into that delivery room, it was kind of like, you know, this is what's happening, this is what we're gonna deal with. And so what can we do? Well, in my opinion, until the systems that contribute to poor birth outcomes for Black women are changed and made to work for us, I feel like we need to be able to provide Black women with the support they need to navigate these systems for themselves. And that includes, you know, for me, 3 main things: information and education. You know, education first on lactation, but also information just on induction rates. If I had known what the induction rate for my OBGYN is, I might have made a different choice. I may have asked more questions. I may have advocated for myself more. Or if I knew the percent of NICU babies in that hospital that were bottle feeding, even though it was baby friendly, I assumed that they took those steps in care. So I wasn't prepared for that either. Also, one-on-one support, that is huge. One of our other speakers mentioned how it's so critical that doulas are coming, you know, and they're more widely known, and funding is coming out for them. And having that one-on-one support where you are their priority, I think is so important. And that can be a doula, but for me, it can even be just a nurse who is culturally competent, who understands you, who is there to support you and hear you. And also, I would say finding a care team that's culturally competent. You know, for me, having that nurse, and because she was a visiting nurse, that was the only reason she was in my hospital. So systems like that, having more mechanisms for nurses to be able to travel to places where less nurses of color reside. Things like system changes like that can really impact women who are in places where they just don't see healthcare personnel that look like them. Also, I think in terms of my own sort of overall experience, I think that if we can Black women play a role in our own health and safety, we have to. Unfortunately, you know, we can't always rely on systems. We can't rely on baby-friendly designations. We can't rely on credentials to necessarily bring us through our birth experience. We have to educate ourselves. We have to seek out the support that works for us. And we have to be vigilant to really take ownership, but also make sure that our voices are heard. For me, throughout that experience, I didn't feel valued, and it impacted my confidence after I gave birth. It made me feel like maybe I wasn't ready, maybe I didn't understand, maybe I didn't know what was happening. So I think that's so critical to really reach moms and give them the tools that they need, I think, to make sure that their birth experiences are empowering, that they are positive, and that they are affirming, because that is how we build strong mothers. I think that's it from me. I just want to thank you all for just having an opportunity to speak on this and to share some of my experiences. I too read about Shah-Asia's untimely passing and just thinking that could have been me, you know? And so I'm just so grateful for all the women and all the people who are working towards making Black birth experiences safer, making sure that, because we deserve to give birth in a safe and empowered way. And we deserve to have a dignified birth. And sometimes even for women who have lots of privileges, we are still denied that. So thank you all.
It's our honor to have you as a guest speaker in this event. I think your perspective is so critical to this conversation. And a little birdie tweeted in the chat that you're also a LA Justice Fellow who co-authored a motion.
Oh, yes.
The LA County Board of Supervisors to find funding for expanding doula services. So you are definitely a champion, and I think your bravery in sharing this story is going to inspire many others.
Thank you so much. I appreciate you all, and thank you.
Next, we're going to hear the voice of Miss Nakia Fields, who is the owner of Fields Family Counseling Services, which specializes in mental health services for the complete family unit. Nakia has over 12 years of experience in developing and running community-focused programming. She's also the founder, president, and chair of the board for the Therapeutic Play Foundation, a nonprofit that seeks to build a healthier, more resilient world for those in disadvantaged communities. Her presentation today will link toxic stress and trauma and frame toxic stress as a mental health issue through its impacts on our nervous system. She will also be giving us a call to action for moving forward. Please join me in welcoming Ms. Nakia Fields.
All right, happy Friday. As a Black woman, a mother, and a business owner, I wear many hats, like so many of us. But the hat that I'm wearing today is that of community advocate for the Black community and our mental wellness. Toxic stress and racial trauma is a mental health issue. Everything that the physicians and Stella just spoke about impacted their mental health and wellness. As a witness to so many stories of pain, stress, and injustice when I am acting as a mental health provider, I want to talk about Black productivity. The story many of us have about our role in this life, how able we are, how we've got this, how we're strong. We are often placed in the worst situations, and our trauma response is to expect it and accept it. Because when we resist, we can be labeled as thugs and criminals. Sitting in discomfort becomes normative. Life becomes just surviving, one day bleeding into another, and we keep moving. We become numb and in survival mode. Our primary motivation being pleasure to drown out the pain and competing for resources to get our basic needs met. Sometimes even intentionally tearing each other down to get what's ours individually. Survival of the fittest, not building together. Villages destroyed, culture interrupted. Knowing from our history with Black Wall Street in Tulsa and Seneca Village in New York, that when we are able to attain a community and it is prosperous, danger lies near. This hard life of labor is not our truth. We see others with more means and safety, living with no care as to what can happen to their bodies and their families, seemingly free of our burdens. They are not like us, moving through milestones, lackadaisical and ignorant to what it's like to be Black. We witness them having the privilege of just being. To be in the community pool or park without harassment is our type of luxury. Ah, the life. To be Black is to experience colorism and the assignment of value based on hue and brown paper bags. So disposable and useful, those brown paper bags. To be Black is to see injustice in someone who looks like you dying in front of you on the regular and knowing deep down that you or someone you love could be next. To be Black is to know that our behaviors are policed by law enforcement and society alike. We can't be mad. We can't be sad. We can't be silent. When we are either, we get labeled as an angry, mean, antisocial Black employee, unable to have a bad day. To be Black is to go to the doctor and leave feeling unheard and uncared for, worried that anything you shared will result in pain and suffering for your family. To be Black is to feel sick and to be told you are not. performance skills on high to keep that job and keep that food on the table and to keep our children in our care. To be Black is to deny our truth, to restrict our voice, to show up in mask in order to attain a certain status. To be Black means that just like with the brown paper bag, we are disposable to some. To be Black is to compete for resources and to experience the need to code switch when we are around mixed company. To be Black is to experience being confused with another Black person in the organization just because there are only a few of you. To be Black is to feel isolated in our aloneness when we make it into rooms when we thought we were supposed to be there. People treating us as if we are lucky, like we won the lotto, and not because we are amazing creatures who have beaten insurmountable odds and clawed our way there. And still we work with a smile and a little dance. We are productive. We are lazy if we rest. It's almost as if our ancestors were taught long ago and passed down the thought that most of our worth resided in our ability to do labor, to get things done, to be of service. This teacher, this educator of what is expected of living while Black is long gone, but the gatekeepers remain. The lesson remains. The message remains. Keep working. Stop taking breaks. Serve. The time of enslaved minds to the thought of that service and productivity is what brings us value is over. We must claim a change in thought. We must engage in self-care as a form of radical protest. As Audre Lorde stated, caring for myself is not self-indulgence. It is self-preservation, and that is an act of political warfare. And Melissa, I invite you to move forward a few. You can see the data that Dr. Taskamore, Dr. Kim Gregory, Mashariki, Stella discussed. We are not treated as if we are cared for. Let's chat a bit about how our bodies are impacted by not resting. You've been advised already from our previous presenters by the constant inflammation of our complex and transgenerational trauma that have been passed down through our genetics and through our stories. It has resulted in disparities in health outcomes that are unavoidable. Toxic stress is a mental health issue. We are dying because we cannot heal, because we cannot rest, and we cannot feel safe, and we cannot do what our bodies are supposed to do. We have limited safe spaces. We are on fire, literally, in our nervous system, and our institutional structure and systemic constructs have yet to address what we know is at issue. We must address the extreme inflammation of our nervous system by giving it a chance to rest and return to parasympathetic space. We must pause so that the toxic stress our bodies are constantly feeling can be addressed. We must remove ourselves from the chaos we subconsciously create in our behavior patterns that keep us in that fear response. We must let go of any stigma around love, affection, and caring. We must love each other. We must address mental, physical, and spiritual health first. We must care when we feel ill or sad or down and not just power through. We are so used to fear and adrenaline that comes from strife that at times we welcome it as the norm. After all, living while Black is to be alert and aware and prepared for danger at all times. Will our survival skills get muted if we don't constantly practice running from the giant dinosaur that represents the specter of our oppression? Imagine if we let that go. Imagine if we attained feelings of safety within ourselves and our communities. Imagine if we created routines of wellness and intentionally operated as our most self-actualized selves in a uniform and strategic way because we feel well enough to do so. What if we connected and powered ourselves forward beyond just basic needs and into comfort for more than just a select few? What if we stepped out of intentionally placed lessons of fear and shed that old belief of where our values lie? The possibilities are endless when we are optimistic. We must first believe change is possible in order to step forward and demand it. To be Black is to be worthy of rejuvenation and restoration. Let's commit to healing enough to acquire it as our due. I call us to action to have our voices heard. Join the movement to make change in the way we receive healthcare. We must demand a change in the narrative, starting with decreasing stigma around what mental health care is. Mental health care is brunch on Sundays, family game nights, a nice walk in the sunshine, a word from your pastor, a hug from someone you haven't seen in a long time, and yes, maybe even a yoga class. a sound bath, a drum circle, or toting around your favorite crystal. The intent is to soothe and create safe spaces when we need them. We must be intentional and radical in our self-care because we are in crisis. Self-care is the most absolute form of protest we can take in these times. When we care for ourselves, we are not allowed to convince us. They are not allowed to convince us. No one is allowed to convince us that we do not deserve equitable care. Join the movement on September 29th at our San Gabriel Valley African American Infant and Maternal Mortality Community Action Team launch party. And join us as we bring awareness to the importance of mental health and decreasing mental illness and toxic stress by being a part of the cast production team or investing in the Therapeutic Play Foundation's upcoming documentary series, Black Mental Health, Changing the Narrative. This documentary series is a purposeful visual aid to show them what is going wrong so that they can't ignore us and avoid us and tell us that we are lying, that it is not true. Let us make this movie. Let us make this change. We will do it. We will take control of the narrative, and we need your voices to do so. We have seen how storytelling empowers. Let's stay on trend. Thank you, Melissa. Please show the promo spot.
Therapeutic Play Foundation, a nonprofit 501c3 organization, is dedicated to addressing the stigma around Black mental health in order to improve overall health outcomes for persons of Black heritage. Our documentary film series, Black Mental Health, Changing the Narrative, will continue outreach toward improving Black wellness. Through images and data, we will increase awareness of the impact of mental illness on our bodies and spirit, and intentionally allow ventilation, processing, and healing. Films are powerful media outlets that can be screened in theaters, TV, and digitally to gain broader reach. And there is strength in numbers. Data shows that there is a disparity in the way services are provided to Black bodies. The current situation with COVID-19 and its impact on the Black community demonstrates this. We want to provide knowledge and resources to influence a change in the narrative around mental health and norms around treatment or lack thereof. Not only is this series about addressing the maladaptive trends that are showing up in reports on the health outcomes of Black families, we also hope to depathologize individual suffering and address the Black community's social determinants of health and where improvements can be made systematically. Black Mental Health, Changing the Narrative explores why Black people disproportionately suffer from poor health outcomes, as well as promotes strategies and resources that assist in improving their overall health and well-being. The connection between toxic stress, complex trauma, the transgenerational impact of enslaved history, and health outcomes will be addressed. Black Mental Health, Changing the Narrative aims to destigmatize mental health and increase positive birthing experiences, birth outcomes, and healthier families in the Black community by providing a psychoeducational visual aid to empower action, community building, and civic engagement. Join the movement to make change. Join the movement to have your voice heard. Join the movement to heed our call to action. Visit blackmentalhealth.net to learn how to submit your casting video. Join our production team, donate to our cause, or join our community action team. Storytelling empowers. Join us in changing the narrative.
All right, so you know the website to go to get involved with this documentary. You also know about the event that's coming up on September 29th, our CAT launch party. And you also know how to get on our emailing list by emailing Annette at the emails shared in the chat. So we also have the pleasure of hearing from Raina, who's going to share a little bit about the county-wide African American infant and maternal mortality, those questions. But please join me in welcoming Raina Granferry.
I wanted to say good evening, and I'm just so pleased to be involved with you all. Everything was just so dynamic, from Dr. Gregory to Dr. Moore to Stella to my Shariki. It's just been, Nakia, it's been phenomenal. So I just wanted to give a brief overview. I know that a lot of you have been involved and know a little bit about our AIM coalition and what you're a part of here, which is the AIM Community Action Team. So of course, AIM stands for African American Infant and Maternal Mortality Prevention Initiative. It is a community county collaboration along with First 5 LA, who really came together to put a lot of different pieces together in order to really make a difference and attack the gap, I'm so sorry, it's been a long day, to attack the gap in disparities. So this is our website here. We do have a full community outreach and awareness campaign, and it's blackinfantsandfamilies.com. You can go there. We also are Black Infants and Families on Facebook as well. So I can have the next slide. So these are our goals here. So the aspirational goal is to eliminate racism and reduce the effects of racism on Black women's bodies. That is the overall goal. Yes, we are focused on Black infants and their mothers, but mostly even reproductive justice. We want to just eliminate all the disparities around how Black women's bodies are seen and treated and valued. And then the initiative goal is to reduce the Black-white infant mortality gap in LA County by 30% over 5 years. And that's to 2023. And the County of Los Angeles has made this a priority. Our deputy director, who many of you see almost every other day on the news, you know, giving updates for COVID, has said that, you know, very proudly and loudly that racism is the root cause of this, and that the county is going to direct funds and human resource in order to make this 30% gap shrink in the next 5 years. Next slide. So now I just want to give you a little bit of information. I know I only have 5 minutes, so I'm going to go very quickly about some of the progress in our initiatives. So we started in 2018. We had our first meeting. Oh yeah, we could just stay at that slide. I'm just going to make it real quick. We started in 2018, and we had a kickoff meeting at Kaiser Baldwin Hills. There was about 100 people in attendance, and everyone just came together and said, you know, it was community members, physicians, doulas, social workers. So many people showed up to say that they wanted to make a change in LA County. And since then, we've grown. We have a community action team in South Bay and South LA. We have a community action team in the Antelope Valley. Both of those community action teams are over 100 people. We have here, you all here at the community action team, you guys are getting started and getting ready and already rolling with so many activities and so many dedicated people. It's very exciting. And in that time, we've had anti-racism trainings. We've done hospital quality improvement with partners such as PACLAC, who's also here with March of Dimes, with Breastfeed LA. There's been a lot of movement there. We've also done work around earned income tax credit, and now we're going to be moving into teaching families about paid family leave. We'll also have fatherhood programs and maternal mental health programs, along with group prenatal programs. So we can go to the next slide. And all of our CACs have work groups who are working on policies. They are working on integrated holistic forms of care. They're working on community outreach. There's a lot of different work groups that are involved. So now I just want to talk to you about our AIM Doula Project. And so the AIM Doula Project was funded by the Department of Health Services, Whole Person Care. And we have 15 dedicated doulas, all African-American women doulas, who are trained in lactation, trained as doulas, of course, trained in trauma responses and care. And they have been working now for a little over 6 months now. We've had about 60 babies. We've got 222 women, I believe, at this point, enrolled in the program or have been enrolled at some point. We started off with our funding only being for SPA's service planning areas 1, 6, and 8, so the Antelope Valley and South Bay, South LA. But now we are reaching out to women throughout LA County. So if we can go to the next slide. That's a very small flyer, but if you're on your phone or even maybe if you have a touch screen, you can make it larger by pinching and zooming. And so as long as you are an African-American woman and pregnant, you are eligible to receive free doula services from our trained doulas. There is no income requirement, although we do prioritize Medi-Cal women. And if you want any more information, you can go to blackinfantsandfamilies.org to get more information about our doula services. And I wish I could give you all more because there's so much going on, but I want to be respectful of the time and let us get to these wonderful healing circles that are getting ready to happen. So I have just one more update on the last slide. So this summer, one very exciting piece of news that we have is that the LA partnership along with LA County has created the Village Fund, which is a small grant opportunity. There will be multi-grants between $5,000 and $30,000 for people in the community. This is directly geared to folks in the community who are not typically eligible or wouldn't be eligible for funding in whatever type of interventions and services and support they give to Black infants and families. So this could be down from, we always use the example like if a Black woman braids women's hair before they go into labor so that they don't have to worry about it and they can still feel beautiful, that person would be eligible. So many things out of the box we want to be able to fund and not have this big rigorous process so that we can wrap our arms around the people who have been caring for our communities all this time and don't fit into the very rigid results-based and evidence-based forms that typically get funding. And we also have an anti-racism training to help folks with to become anti-racist and to become and to make sure that they are not anti-Black. So this is a very important training, and you can also reach Annette as well if you want to figure out how you can sign up to be a part of that training. So thank you all so much for giving me a moment of your time, and I hope we all enjoy the beautiful healing circles that are to come.
Thank you, Raina, so much for sharing this. We do have somebody who wants to get involved, I think, in Antelope Valley. I saw that in the chat. All right, so speaking of the chat, please know that if you do have questions that we weren't able to get to because of time, you can go ahead and email Annette. She will document all your questions and get them to the right guest speaker for you. And everyone who has RSVP'd for the Healing Circle should have received a separate Zoom meeting link. I think the link was also posted in the chat. We're going to transition to that part of our event now, the Healing Circles, which allow us to help process and grow on our journey of empowerment and self-care. And in case you haven't participated in a Healing Circle before, it's a group activity that involves reflection, developing a sense of community within the group, and helps to grow and expand the sense of empowerment among the group members. The facilitator for this portion of our event will be Michelle Rosemont from Prototypes. So I hope to see you guys there. And again, if you have any other remaining questions for our guest speakers, please do feel to put them in the chat. We're going to save the chat or email Annette at the email address that she provided. Okay, everybody, thank you so much for staying on for this informational session, and I hope to see you in the Healing Circles. Bye-bye.